Hello, I'm Dr. Alexander Hampson and I work at the Lister Hospital in Stevenage in the United Kingdom. Thank you to the BJUI for selecting our paper titled The Role of Extended VTE Prophylaxis for Major Urological Cancer Operations as the article of the week. In the United Kingdom, NICE guidance recommends extended thromboprophylaxis for patients undergoing major abdominopelvic cancer surgery with an extended duration of low molecular weight heparin for 28 days postoperatively. Since the review by Tickinen et al. And his work with the European Association of Urology, the latest EAU guidelines are variable and procedure specific, and these reflect the current practices of clinicians around the world. Our aim in this paper was to investigate whether extended thromboprophylaxis should be indicated for all patients undergoing urology cancer operations, as well as looking into procedure-specific data that may influence a clinician's decision. We looked at 18 studies and analysed the three main urological oncology surgeries: radical cystectomy, radical prostatectomy, and partial/radical nephrectomies. We analysed factors such as VTE rates, bleed risk, renal failure, and overall mortality. We found in our study that the VTE risk was highest in both the open and robotic cystectomy groups, and that extended thromboprophylaxis resulted in a significant reduction in overall VTE rates. It was also found that there wasn't a significant reduction in pulmonary embolisms or overall mortality. It was also found that open prostatectomies had a comparable VTE risk along with the cystectomy groups, but that minimally invasive prostatectomies, as well as radical and partial nephrectomies, had a lower VTE risk, and therefore extended thromboprophylaxis may not confer a significant advantage. Ultimately, the decision to use extended thromboprophylaxis is a clinical decision and is made based upon the procedure-specific information such as the VTE incidence and the bleed risk, along with patient-specific information such as perioperative morbidity and mortality and comorbidities. While extended thromboprophylaxis remains a net benefit for open radical prostatectomies as well as the cystectomy patients, the balance is much closer for minimally invasive prostatectomies as well as radical and partial nephrectomies. And we found that due to a lack of procedure-specific evidence for the use of extended thromboprophylaxis, adherence to the national guidelines in the United Kingdom remained poor. Therefore, we advocate further studies directly comparing extended thromboprophylaxis to the standard prophylaxis. We would also advocate for further studies looking at procedure-specific information in order to allow clinicians to make a more informed decision in the future. Thank you very much.